Hey y'all, welcome back and welcome to module 6. Uh, we're this week gonna mark, what, 3/4 of the way through this term. And this week we're covering a couple of more or less unrelated, at least not directly, classes of disorders, personality disorders, and gender dysphoria. In this video, we're going to cover just some ways of kind of personalizing and thinking through personality disorders. I have included a case example underneath this video in the item on Blackboard, but we're not necessarily going to go through a sort of a vignette report like we have for previous classes or previous videos, just for a couple of reasons. Number one, to save time, because there's a lot to cover in this class. And we've done that sort of extensively throughout the previous parts of the term. And y'all have demonstrated that you seem to have a strong handle on that task. So I'll be doing what I can to kind of give perhaps some personal examples of work that I've done with people dealing with personality disorders. And hopefully that will personalize it, give you a frame of reference for when you see this in your own pre and professional experiences. Personality disorders, similar to OCD and trauma, have gotten a lot of attention in our common discourse. And I hope that today's video will, again, help you to sharpen your clinical eye and your clinical thinking about this class of disorders. And they get a lot of attention because they can be sort of sensationalized in media. They often have an impact on not only the person dealing with them, but with the social situation or social sphere around the person that can be at times pretty significant. And they can be it can show up as such a departure from what is expected from interpersonal relationships that it can be very confusing. And the topic of personality really isn't necessarily well understood in our common discourse. So I think it's important that we start with sort of a definition, just a review of what personality is and what are kind of the key characteristics of personality expression and experience that is associated with pervasive and persistent suffering for people in our society. So personality generally is considered sort of a collection of traits that influence a person's inner experience of themselves and their interpretation and relationship with their environment, primarily their social environment. But that doesn't have to be exclusively the social environment. And this class of disorders generally are characterized by an enduring pattern of inner experience and behavior, that is the expression of the inner experience that deviates markedly from the norms and expectations of an individual's culture. B, is pervasive and inflexible. So it shows up throughout the person's life in a way that is almost dependable, right? Like it doesn't really deviate from the pattern. It doesn't change much. It can be sort of a rigid adherence to the pattern. C, has an onset in adolescence or early adulthood. Okay, so it starts to manifest. Usually, we're going to start seeing signs of a personality disorder around 15, 16, 17 years old. And D is stable over time. So it starts in adolescence and can persist for years at a time. And then, of course, it leads to distress or impairment for the individual. Now, determining distress or impairment may require external, that is, professional assessment and judgment due to the likelihood that the person dealing with the symptoms of the personality disorder are likely to lack insight, just an awareness that what is manifesting in them is maladaptive and sort of defeating and interfering with their day-to-day functioning. Oftentimes these are, the term I'm referencing is this idea of egos syntonic, which sort of is a fancy way of saying that a person that is manifesting these symptoms really has a firm belief that they are, these symptoms are essentially aligned with this person's best self. They don't see a reason to change. They think that their behavior is often justified and good for them. Just a heads up about that. Insight is a really important sort of characteristic of personality disorders. So manifestations of the identifiable and maladaptive pattern that's characteristic of a personality disorder, they occur in one or more of the following domains or areas of a person's life. So they show up in cognition, that is sort of ways of perceiving and interpreting the self, other people, and events in their life. Number two, sort of affectivity, or in other words, the range, intensity, and lability and appropriateness of the emotional response. So keeping in mind that lability is a fancy way of saying that the person, the affect of the person is likely to change. Some people use the term mercurial, and that's referencing a sort of a metaphor for literally the metal mercury. If you're familiar with the metal, mercury is very sensitive to the environment. That's why it's used in thermometers, that if heat is presented to mercury, it will respond in a very sensitive, very quick way. So lability can almost be sort of transposed with mercurial, big ups, big downs, and quick changes in range between them. So again, manifestations include cognition, affectivity, that is the range, intensity, lability, and appropriateness of the emotional response. That's referencing sort of the degree to which the person's emotional response matches the circumstances through which they're living. Sometimes they can be just bigger than is necessary, or more inhibited than would be expected. So again, cognition, affectivity. Number three, sort of interpersonal functioning, that is social functioning. So clinically, we're wondering, can the person assess, develop, and maintain relationships across differing levels of intimacy? For example, collegial, spousal, sort of peer friendship types of intimacy. And are these sort of capabilities within expectations for their developmental level? And then number four, these manifest as sort of impulse control. Oftentimes there's a lack of impulse control when working with someone dealing with a personality disorder. Again, of these four, at least one or more must be present for a personality disorder to be diagnosed. This class is organized into three alphabetized clusters: cluster A, B, and C. Cluster A are considered sort of the odd or eccentric personality disorders. Cluster B, which probably gets the most social and clinical attention due to the impact that they have on a person's intra and interpersonal functioning, as well as their social setting. This is the dramatic, emotional, or erratic cluster of personality disorders. They are often associated with chronic trauma in the clinical sense. And then cluster C is composed of the anxious or fearful personality disorders. Now, in cluster A, you have paranoid personality disorder, which is characterized by a personality that is maladaptively suspicious or distrustful of others. You have schizoid personality disorder, which is sort of the manifestation of a detached, restricted affect. There's a notable lack of interest in relationships. People that are dealing with schizoid personality disorder don't really see the point of interpersonal relationships. And then thirdly, you have schizotypal personality disorder. Now, you may remember seeing this referenced earlier in the term when we were covering the schizophrenia spectrum and other psychotic disorders. Schizotypal personality disorder is considered part of the schizophrenia spectrum because there is the likelihood that psychotic type symptoms, particularly delusions, will be present. And this is sort of a personality disorder that is characterized by acute discomfort and reduced capacity for close relationships. So paranoid personality disorder, suspicious or distrustful, okay? Schizoid personality disorder is detached personality with little interest or value in relationships. And then schizotypal is characterized by discomfort and reduced capacity, a capability to develop and maintain close relationships. And all of these are differentiated from psychotic disorders because the personality pattern preceded the psychotic symptoms if they are present, and or the symptoms resembling psychosis, such as delusions in particular, are not held with delusional conviction. There's a little bit more or maybe a little bit less resistance to other points of view related to the psychotic type symptoms. So that is cluster A. And we'll get into prevalence in a little bit, but this is sort of the middle ground in terms of prevalence of personality disorders. Cluster B, as I mentioned before, the dramatic and emotional or erratic class or cluster of personality disorders. Again, probably gets the most social attention and is the cluster that features the personality disorders you've probably heard of before. The first one is antisocial. Secondly, we have borderline personality disorder, then histrionic personality disorder, and then finally narcissistic personality disorder. Now, antisocial, and all four of these have a history of being used in our common vernacular for better and for worse, and that they're used often in ways that are not accurate understandings of what these disorders actually look like and how they actually impact the person dealing with them directly and their social environment. So I think the first one in the class, antisocial, is a great sort of place to jump in here about that. So antisocial personality disorder or being antisocial is often conflated in our common discourse with introversion, okay? And so antisocial personality is not an introverted personality. Introversion in and of itself is a trait that is characterized by a preference to spend time alone. So perhaps an introvert recharges their batteries, so to speak, when they're alone. This is sort of the Netflix in a quiet space on a Friday night by themselves, as opposed to an extrovert who, on the most pure end of the introvert extrovert spectrum, is kind of the Friday at the club kind of crowd. They recharge by being with others. Antisocial personality is actually associated with disorganized attachment. It's notable for its lack of empathy and perspective taking. And it's vastly overrepresented in incarcerated populations because of the sense that a person is feeling empowered by violating the rights of others and causing others to suffer. People dealing with antisocial personality disorder are often sort of manipulating others to the point where they're hurting them, stealing from them, perhaps even going so far as to murder others as a way of feeling empowered. And so this is a very, very concerning pattern, very dangerous pattern, and again, is often overrepresented in incarcerated populations. It has been shown to have a strong genetic component, which makes it a little bit, or sets it a little bit apart from the other disorders in this class. So what I mean by that is that a person, or I guess family members, are likely to demonstrate the symptoms of antisocial personality if one of them has it, regardless of environmental factors. So this is particularly true for parents or siblings, especially if the siblings are twins. Again, you may have heard people talk about sociopaths. This is often what a person is referring to. This personality disorder is what they're referring to when they use that term. It's perhaps not the greatest term to use. It's certainly stigmatized. However, there's certainly a pattern of pathological social interaction that is not necessarily disinterested, but is destructive of social relationships. I'm trying to think of other ways to kind of make that clear. I look forward to your questions if you have them in the discussion board. Now, you may have also, like just similar to antisocial personality, you may have also heard the term borderline personality disorder. This term is often overused, misused when a person displays sort of emotional lability or dysregulation. But it also pretty severe. It is likely, a person dealing with borderline personality disorder is very likely to require acute hospitalization at some point in their life due to the likelihood of self-harm or suicidality. It is characterized by a very strong and effortful pattern of avoiding real or perceived abandonment, and often is sort of characterized by great difficulty with understanding and respecting interpersonal boundaries. Again, just like the other personality disorders, this one also has a enduring quality and sort of a resistance to change in clinical settings to the point where I think if you're working in especially a community-based clinic or an acute care setting, clinicians become sort of exhausted by working with people with this presentation, because of the amount of investment a person may put into the work with a person with borderline personality that does not uh, return the effects that they might expect. And so when this happens, what is common is sort of a depersonalization of a person dealing with borderline personality disorder. So you may hear people start to call people borderline um, in a very sort of way that I think is intended to convey exhaustion and displeasure, but is also quite unfair and stigmatizing to the person dealing with the condition. Uh, so, and also at times, the exhaustion is quite understandable because the presentation can be quite troubling and severe. So I'll share with you sort of an example of this type of thing from my own professional experience, having worked extensively in a community-based setting. This was sort of an outpatient community-based setting. I was working with a woman, middle-aged, married, had 2 children, and she, like a lot of other people dealing with borderline personality, had experienced significant trauma. It is often the case, but not necessarily with this client, that a person has experienced some type of sexual trauma when sort of presenting with borderline personality disorder. Toward the, and you'll later, maybe a year or more into our work together, there were changes happening in my professional life that required that I refer her to another clinician that were just part of developmental changes in my own life. And my client was understandably upset about this. And the way in which she expressed her displeasure showed up in a couple of really important ways. So just for a little context here, at the agency I was working at, this is actually a fairly common practice these days, we used our personal mobile phones as our business lines. And so a lot of folks these days are doing that, but getting around having like a personal number given out to clients by using like Google Voice or something like that. But in this case, this client had my cell phone number, and she also knew some details about my personal life. So she knew what my wife looked like, how to recognize her, and she lived in a neighboring town. My wife went to that neighboring town to meet a friend from college who happened to be a guy. And this client, I'm led to believe, spotted my wife and this friend walking down the street as they were headed to get lunch. And on the same day that was happening, I got a voicemail with this person's, it was recognizable from her voice, wanting me to know wanting to know, or at least asking if I knew where my wife was. Not too long after that, I think I had posted on social media that my wife and I were planning on taking a ski vacation to the Rockies. And she called again and left a voicemail in sort of a haunting voice. Have fun in X location. There were also, in addition to this, a few instances of vandalizing my car. in one instance, it was outside of my office. I went outside during the lunch hour to grab some running clothes. I was going to change and go for a run during lunch, and went out to discover that my locks on my car had been glued shut, and there were some offensive words written in permanent marker on my car. And so this is the type of thing that may occur and are sort of indicative of sort of the affective and emotional response and appropriateness and impulse control problems that are associated with personality disorders generally, and especially when they are kind of manipulatively threatening like this. They are indicative of borderline personality. Next in the class is histrionic personality disorder. This is a personality disorder that is characterized by sort of overly dramatic or seductive, provocative types of behavior that's intended to help maintain the centrality of a person's attention upon the person with the disorder. There's often sort of rapid shifting of and shallow emotion between rage and helplessness. This is differentiated from borderline personality in that it's not as self-destructive typically as borderline personality disorder. And there's also the way you differentiate this from narcissism, because histrionic personality disorder is a presentation that sort of demonstrates a craving to be the center of attention, discomfort when a person is not center of attention. So this is different than narcissism, which also craves attention. But histrionic personality is more willing to be fragile and present as fragile as an attempt to gain and maintain attention, whereas narcissism craves attention for their superiority. Now, that's a nice segue into narcissistic personality disorder. So have you ever seen, for those of you who have seen the Disney movie Moana, the character that jumps to my mind when I think about narcissism in a clinical sense is Maui, in his sense of entitlement. This presentation also lacks empathy, similar to what you might experience with antisocial personality. But narcissistic personality is more grandiose than antisocial personality, and is not as impulsively aggressive or deceitful as antisocial personality. Excuse me for a second. So, excuse me. If you're dealing with a person that is presenting with a narcissistic personality disorder, you are less likely to be in actual danger than you might be with a person with antisocial personality disorder. So that kind of concludes our review of cluster B. And again, if you're working in a acute care or community-based setting, especially those that are often have contact with people that are a threat to themselves or others, you are likely to come across clients with this type of presentation. Cluster C is the avoidant or fearful cluster. And so this includes avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. Avoidant personality disorder is sort of socially inhibited with feelings of inadequacy and great hypersensitivity to criticism. Dependent personality disorder features sort of chronic indecisiveness, submissiveness, and clinginess. And then obsessive compulsive personality disorder is characterized by a preoccupation with orderliness, perfectionism, and control. And again, the similar to cluster A, the symptoms that resemble obsessive compulsive disorder or other OC types of disorders are not demonstrated with the same level of clinical severity. And they often have, again, like a personality disorder, begun to manifest in adolescence or early adulthood, whereas OCD can start to manifest in childhood and are more closely associated with sort of difficulties with cognition, affectivity, and interpersonal functioning, and more sort of a part of a person's sense of their own identity and personality than may be typical of OCD or other obsessive compulsive types of disorders. Prevalence of personality disorders may be surprising. According to the DSM, 5TR, and this has been a little bit of this number has lowered a little bit in between DSM-5 and DSM-5TR, but essentially we're looking at a little bit more than 10% of the population may have some type of presentation that is indicative of a personality disorder. It's important to note that the DSM-5TR sort of talks about median prevalence among multiple samples and epidemiological studies that have been evaluated across different populations or countries. And so keep in mind from your statistics courses that the median is the middle prevalence number for the samples evaluated per cluster, not the average. The mean is kind of when you add up all the prevalence numbers and then divide them by the number of people involved. In this case, they took the means of multiple studies and picked out the numbers that happened that were in the middle of the samples evaluated. So these numbers in the DSM-5TR do not give you an average number of people who have the disorder, but can give a ballpark sense of how prevalent the disorders are nonetheless. Cluster B is the most prevalent at 4.5% as a median prevalence. Cluster A has 3.6% as a median prevalence, and then cluster C is 2.8%. So I have put the case example of Jane in sort of a PDF within this video item. I look forward to seeing your provisional diagnoses in the discussion board for this module. This is not required, but if you are interested in getting exposure to another case example, I'd be happy to discuss Jane's presentation with you in the discussion board for this module. And that concludes our sort of review and discussion of personality disorders. I look forward to seeing you in our next video. Thanks.